Hi everyone. I'm just waiting for a few seconds for people to join us, and thereafter I'm going to invite Dr. Brighten. Hello everyone. Good to see you. That's great. I see some waves. Hi. So it's a lovely day. It's almost spring here in Toronto. Beautiful, beautiful weather, sunny. And in this beautiful weather and beautiful day, we are inviting lovely Dr. Jolene Brighten. Amazing and incredible. I'm just waiting for some people to join us. So as usual, I always say if you have any questions, you can just type it in the comment or in the question box. Hi. Hi Nasrain. Hi Iman. Good to see you all. I'm so excited for this talk. So many questions for Dr. Brighten. So, hi. Hi Nazi. Good to see you. Okay, so I'm going to invite you can start typing your questions. We try to go through them as many as we can today. If not, of course, later I can address those questions. Okay, let's see. All right. Hi, Judy. Good to see you all. You can type in where you're from whilst we're waiting for Dr. Jolene. Hi, everyone. Hello, hello.
Hi, how are you?
I'm good. How are you?
Good.
Good
Yeah, thanks
to
for
see
having
you.
me today.
Pleasure. It's an honor. So, how are you in this beautiful day?
I'm doing great.
Great to see you. So before we dive into questions, I just take an opportunity to introduce ourselves for those viewers who are new here. I'm Dr. Bahar Amin, family doctor from the UK and functional doctor, anti-aging, metabolic fellowship. For last 5 years, I'm doing my private practice, seeing patients here in Toronto. We are all eager to hear your story. If you could give us a little bit of intro about yourself, that would be great.
I'm Dr. Jolene Brighten. I'm board certified in naturopathic endocrinology, which means I'm an integrative hormone doctor. I have a background in nutrition science, chemistry. I'm also a certified sex counselor. So I spend a lot of time talking to women about all things women's health and how hormones affect every single system in our body.
Absolutely. Great. Amazing, incredible, Dr. Jolene. So let's start some questions. Women, polycystic ovarian syndrome. So this is a leading cause of infertility in women. And interestingly enough, at least in my practice, I see many of these women haven't been diagnosed for many years. Even they having a history of some irregularity with their periods or some hirsutism, and they've been on birth control pill forever, until they decide to have kids and have children. And that's the time they stop their pills and they not get pregnant. And they start the investigations and diagnose with polycystic ovarian syndrome. So if you could let us know how you approach diagnostics and all the hormone imbalances picture, what is the treatment and lifestyle, nutrition, supplements.
Yeah, so that's a huge area and a huge topic. So for everybody who's watching, you can let me know, are you familiar with polycystic ovarian syndrome, also known as PCOS? As you said, it is a leading cause of infertility. And the most common prescription women are met with is the pill. And this is why so many women don't understand what is going on with their body. When they come off the pill, they lose their period altogether. They can't get pregnant. It's because they were offered the pill for irregular periods without any discussion as to why they had them. Or perhaps they were offered the pill for acne. And these are two of the leading symptoms of PCOS that are also mandatory for the diagnosis. So there's the Rotterdam criteria. This is the criteria where you need to meet 2 out of the 3 to meet the diagnosis of PCOS. Now, while it's called polycystic ovarian syndrome, that's misleading. There's not cysts on the ovaries. There's actually follicles, and we don't see them in everyone. So a transvaginal ultrasound is what you need to visualize those. But if you already have ruled out other issues going on, and what we find is that you have irregular cycles due to anovulatory cycles, so you lack ovulation, and there are signs and symptoms of hirsutism, and signs and symptoms of hair loss, signs and symptoms that accompany oily skin, acne, things like that, that falls into the camp of hyperandrogenism. And if we see those, it's very important. Clinically, we can make the diagnosis. We don't have to have lab testing, although lab testing can be helpful to understand where are those androgens coming from, because sometimes they're coming from the ovaries, sometimes they're coming from the adrenal glands, and that can help in terms of guiding treatment. So you asked about like, okay, well, what's the treatment? What course of action do you take? With PCOS, roughly 70% or more of those with the condition have insulin resistance, blood sugar dysregulation. And with that insulin resistance, when insulin goes high in the PCOS ovaries, that stimulates androgen production. So that will cause the ovaries to make more testosterone than they normally would. This is why some people say that PCOS is actually diabetes of the ovaries. So we'll hear this, there's diabetes of the ovaries. You may have your diabetes of the brain, which is what Alzheimer's and dementia has been classified as. So if we know that insulin dysregulation is at the crux of driving androgens, which are the main symptoms that people complain about. However, those androgens can be related to why you're not developing a healthy egg if you're wanting to get pregnant or being able to ovulate. And where we need to work is on that blood sugar piece. The 2023 guidelines just came out on PCOS, and what they told us is what we've been shouting for a very long time, and that is that nutrition and lifestyle are the very first intervention. There is a time and a place for medications like metformin, maybe spironolactone, maybe birth control, but that's not where you start. Unfortunately, that is where most practitioners are starting with their patients. And so what we want to be focusing on, optimizing nutrition. It's not just about stop eating carbs. It's about increasing protein, increasing nutrient density, increasing fiber, and increasing resistance training so that you build muscle mass. And we have those pieces, we have sleep, we have all of these lifestyle components. And you ask questions about supplements. Before I dive into supplements, because like I said, this was a really big question, I just want to pause and see, like, is there anything about that maybe we should discuss in more detail?
So I think a lot of people have that, so a problem with, again, I see in my practice, a lot of these women are very distressed, prone to depression and anxiety with polycystic ovarian syndrome. So where is that exactly coming from? Again, is that related and linked to hormone imbalance? Could it be the cortisol level is elevated. So I see that quite a lot. So they
Yeah.
and sleep problems.
Well, two things you just hit on right there, anxiety and sleep problems. We always look to progesterone. And if we have a condition in which you do not ovulate, you will not make progesterone. The way to ample progesterone in the body is through ovulation. And it is only natural progesterone, not progestin found in IUDs or birth control, that gets metabolized into allopregnenolone. And that is going to stimulate the GABA receptor in the brain. That is going to make you feel more calm. You're going to get better sleep. You're not only going to just fall asleep, you're going to stay asleep and have a restful night. So that's one piece. We know that when there is inflammation and blood sugar dysregulation, people feel more depressed. They have more anxiety. They have a higher risk of mental illness. And so that can be going on as well. And then there's the component of you've got cystic acne along the jawline, you're losing hair on your head, and you're gaining weight uncontrollably. And these things can also weigh on our mental health as well. I see that there's Cavaldez, 24, your 21-year-old gained weight, irregular cycles, hypothyroidism, just was told PCOS, irregular cycles, was told pill and metformin, already clean diet and exercise. So whenever somebody says clean diet, to me, I have to ask them, what does that actually mean? Because clean isn't a type of diet. Most people, when they say clean diet, they're talking about like, well, they're eating organic, they're eating more whole foods. That's fantastic. But we do have to start asking questions. How much added sugar is coming in? How much fiber is coming in? How much protein are you getting every day? Because it's not just about cleaning up the diet in terms of making sure we're reducing ultra processed food, but making sure that we're getting the right amount of macro and micronutrients as well.
Yeah. I'm looking through.
Yeah, there's a lot of people joining in the comments. You know, as you were asking about supplements, you know, one supplement in particular that can be really helpful is myo-inositol. And in fact, myo-inositol coupled with D-chiroinositol has been really powerful in supporting fertility with PCOS women, blood sugar, helping with their testosterone as well. And we formulated the Dr. Brighten Essentials Myo-inositol Plus to have the right balance of myo-inositol and D-chiroinositol, but with additional blood sugar support and things to help with symptoms like hirsutism, like using spearmint. Spearmint is something that you'll hear a lot of PCOS women talk about drinking spearmint tea, although it can be challenging for some people where they're like, I'm traveling, I can't get tea. And that's why I'm like, let's make a formulation where it's got everything packed in it so that you get what you need and it can help you along with the lifestyle and nutrition to really support your body.
So one of the, again, presentations I see, like a young woman coming to the practice and she has been on birth control pill for many years, now wants to come off and decide to have family and get pregnant. But then there is months, even years of not resuming the cycle back. She is not polycystic, but this is again another very common presentation I see, and it could be very distressing for women not having their cycles back, the cycles they had before very regularly without birth control pills. So that's again a pretty complex dilemma that we deal with every day.
Yeah. Well, as I talked about in my book, Beyond the Pill, what is crazy to me is how women are told they're put on the pill, and anyone, if you're watching, if you were told this, hey, you just take the pill and as soon as you come off of it, you can get pregnant right away. They're told this. And then when they later come off the pill and they find that they lose their period and there's a delay to the return of ovulation, at that point, doctors are like, oh yeah, well, we expect that. With the pill, it can take you 3 months before you start ovulating again. So for everybody listening, ovulation precedes menstruation. You won't start your period again until you start ovulating again. And the main mechanism of the pill is to shut down brain-ovarian communication. And this is a temporary thing, but it can take some time to reestablish that brain-ovarian communication as you come off of it. It is well acknowledged that Depo-Provera, for example, that is an injectable contraceptive, that we see women who want to get pregnant, we tell them at least 18 months. You'll have to stop this medication before we expect that you will resume ovulation. Now, some people will start ovulating sooner. Some people will come off the pill and they start ovulating right away. But there are a lot of women who see this delay in ovulation. And this is an important conversation that we have because women are using the pill for a whole host of reasons, primarily for symptom management. And in the case of, like, let's say acne, for example, you don't necessarily want to come on. You're like, I want to have a baby in a couple of years, but why would you want to deal with acne now? But you might be 38 thinking, well, I want to have a baby in a couple of years. Well, your doctor told you at 14, as soon as you come off, you'll be able to get pregnant. That's not necessarily going to be true at 38, at 39, at 40. And so that's a case where we would want someone to come off sooner, because if there's a delay to ovulation coming back, but you're already in this perimenopausal window and we don't exactly know what your hormone status is, and we can't measure your anti-Mullerian hormone, which is a marker of your ovarian reserve, like how many eggs do you potentially have left. We can't do any of that to assess, so we have to have someone come off the pill and evaluate it then. And this is where I will see people saying, well, the pill caused me to be infertile. But when we look at the case of what's going on, it's often that their doctor was masking endometriosis or PCOS with the pill and not addressing that, or they decided to come off the pill in their late 30s, which is already a time where some women can struggle to get pregnant. And they feel like, well, the pill made me infertile, but it leaves a big question mark. Is this what your state would have been regardless? Because, well, some doctors will say, well, if you're on the pill and you're not ovulating, it saves your eggs. That's false. It doesn't. We are running out of eggs, and depending on your environmental exposures, your genetics, what your mom did while you were pregnant, what your grandma did while she was pregnant with your mom, all of these factors matter and they weigh in on your future fertility.
And again, commonly I see women on birth control pill who complain about low sex drive, low libido, and we keep switching from this birth control to the other, to mini pill, progesterone only, combined pills, and one of the main reasons they want to come off pill is because they not have any sex drive anymore. So what would you suggest or recommend to these patients to come off, or is there something they can take or do to resume that sex drive they had?
Yeah, so low sex drive is absolutely a side effect of hormonal birth control, and I challenge any doctor who says otherwise to just actually listen to their patients. So one of the ways that they validate whether or not a woman in a birth control trial is actually taking it is by measuring binding proteins. So they know that if they're giving you the pill, binding proteins are going to go up. Sex hormone binding globulin, cortisol binding globulin, thyroid binding globulin. So they sound exactly like what they do is exactly what they sound like. So with that, these binding globulins, they're going to grab on to your hormones. Now, in the case of libido, we've got a couple things going on. So number one is your estrogen, natural estrogen, is not happening anymore from the ovaries because you are suppressing it with this medication. Estrogen is really important in terms of sexual desire, ability to self-lubricate, arousal, sexual fantasies. It plays a very important role. Then there's the testosterone piece. You decrease ovarian production of testosterone, but you still have testosterone production coming from the adrenal glands. However, with a sex hormone binding globulin protein elevated, that is going to grab onto your testosterone. Now you have no free testosterone to stimulate the cells, and it can't get to the receptor. And so that is what's going on. There's also other layers, like some people have adverse mood symptoms when they're on birth control. That can be related to low libido. The other people are having chronic yeast vaginitis. They are having, and these are side effects of birth control, chronic yeast vaginitis. So disruption of the microbiome, having elevation in inflammation, myriad of different factors that I outline in my previous book, Beyond the Pill, can be affecting your libido. Now, there's a lot of things that you can do. And of course, number one is if you ever are on a medication that's optional and you're having side effects that you don't like and they're affecting your quality of life, then coming off of it is what makes sense. But let's say you want to stay on it. Well, there was a study that said, hey, we recognize that the way it takes these androgens, it may be beneficial for supplementing with DHEA. Now, before anyone runs and jumps on DHEA, because it is over the counter in the United States, I want to caution you, because DHEA can become estrogen or testosterone. And if you don't know which, or you take too high of a dose, you might lose your hair and it might not ever come back. So we don't want to do that. Not a good idea. And this is just one study. We need more studies to validate this. But it was interesting to see researchers saying, hey, you may very well need to take additional hormones to supplement what is happening as a side effect of being on the pill.
That's great. We probably have to stop them from taking birth control first place. I mean, it's great contraceptive, but there's so many side effects, as you mentioned. What about, again, another common presentation that I have and lots of questions on premenstrual syndrome and PMDD, or premenstrual dysphoric syndrome or dysfunction, very common. So these women, they have so many symptoms of different craving, headaches, bloating, feeling angry, depressed, low mood, bloating, and breast tenderness during 10 days or a week, 10 days before their periods. So I see, again, a lot of these women already come in with being on SSRIs, cyclical antidepressants, that may help, may not. But it could be, the symptoms could be quite debilitating to the point that impact their work. Sometimes they lose their work, they cannot go back or function because of that severe anger or irritation, low mood. So what are your recommendations with these women? Because it could be very challenging and difficult.
If your PMS is so extreme that it impacts your ability to work or show up in life, that is not likely PMS. You're looking at PMDD, especially if it is lasting your entire luteal phase. So PMS, we expect in a 5 to 7 day window. PMDD, we see can creep into a second week there. And so with both of these, it's important to understand that hormones do play a role. And there are also other factors, right? Like, how well are you sleeping? And I bring this up because research on sleep has primarily been done on men. And they tell us all, 7 to 8 hours, you'll be fine. As women, we likely need more. And we absolutely need more in our luteal phase. And this is something that I see so often in my clinical practice, is that you may be able to, around ovulation, get away with 6 or 7 hours of sleep, but come the luteal phase, when a patient's like, oh, I'm so tired, we start to ask about sleep. If you're still sleeping 6 to 7 hours, well, your body really needs more sleep during that period of time. Lack of sleep, we just went through daylight savings time. Car accidents go up, heart attacks go up. People do not feel well when they lose even just 1 hour of sleep. So understand that lack of sleep can be related to issues with the mood. Now, as I talk about in my other book, Is This Normal?, I actually give a whole diagram showing how when we're losing sleep, this can lead to increased inflammation, blood sugar dysregulation. It can downregulate thyroid hormone production and ovarian function. So this is a type of stress that has to be addressed. And so I bring this up because it sometimes seems like an obvious thing, and then it is the thing that so many people are not doing. Now, with PMS, if you have PMS, you likely have low estrogen, or excuse me, you likely have low progesterone, which is driving you to have high estrogen symptoms. So, sorry, I said that wrong at first. So, you likely have low progesterone, leading you to feel higher estrogen symptoms. I actually just did a post on this on Instagram the other day. And coincidentally, I did a post today, so everyone that's top of my feed, about PMDD and histamine. I'm going to talk a bit about that. But if anyone wants to deeper dive on any of this, you go to drbrighten.com, which is DRBRIGHTEN. You will find tons of information about PMS, PMDD, but also every little symptom that can be coming up and exactly what to do about it. Now, with PMS, if your progesterone is low, we have to look at stress. Now, it may very well be that you are late stage perimenopause, so you are transitioning into menopause, and those cycles, you're not ovulating regularly. Now you're going to start experiencing symptoms of low progesterone. You're not going to sleep well. You're going to feel more irritable. You're likely going to have more bloating, feeling more swollen, more puffy, having breast tenderness. That's common when progesterone's low. But if you're not in that perimenopause phase where you're about to make the transition into menopause, we shouldn't be experiencing that. And if we are, we have to look at stress. So I brought up sleep. That is one stressor. How we eat, what we think, how we move our body, all of these things can be stressors. Now, when we are under stress, the body says, don't make reproductive hormones. Don't try to get pregnant, because that's what the menstrual cycle is doing. Focus on stress hormone production. And that will compromise our progesterone. And if the ovary isn't making ample progesterone, but it still continues with estrogen, you're going to be in that state of estrogen dominance. So you're going to feel that estrogen is stepping on the stage to be the diva during the luteal phase, where it really should be on the backstage. It already did its thing in the follicular phase. So for people who are like, what are we talking about? When you start your period, you're in your follicular phase up until you ovulate. Once you ovulate, you then enter into the luteal phase. And during the follicular phase, estrogen's all about getting the endometrial lining ready and the ovaries ready to ovulate. Once you ovulate, estrogen's still there, but progesterone primarily comes in to finish really what progesterone started in maturing the endometrial lining so that implantation can occur. Fertilization of an egg occurs in the fallopian tube. It is going to take several days, not a week, for that blastocyst to change into an embryo and then to implant into the uterine lining. And so we have to have ample progesterone during that time. And that's what the body knows is important if you want to get pregnant. But if you're signaling from the environment in the way that you're living that now is not a good time to get pregnant, maybe it's even a dangerous time to get pregnant, then your body will shift the mechanism so that it's harder to get pregnant. And it does that to protect you. But it's annoying because then you end up with PMS and you end up in this cycle of not feeling well, feeling really stressed, frazzled, not sleeping. And in the case of PMDD, that estrogen being unchecked can actually cause histamine to go up. So you have these little immune cells called mast cells, and those release histamine. They have receptors for estrogen on them. Estrogen will dock on them, cause the histamine to be released. Histamine will then cause you to have more estrogen. They like work together. They're like besties conspiring. But that histamine, so histamine in the brain can make you feel really aggravated, angry, irritable. And so people who have seasonal allergies, let me know. Do you have seasonal allergies? Tell me some of the symptoms you have when you have seasonal allergies. I would love just for people to chime in here because those symptoms are coming from histamine. And so if people share with us what those symptoms are with seasonal allergies, I bet there's going to be somebody on here that says, I feel that way before my period. And that can be you feeling that as part of your PMDD symptom picture, or you're feeling it on the level of what people call the period flu. And so those symptoms can look like achy joints, feeling kind of feverish, feeling just like I'm so icky right now and run down. That can be a high histamine response, and that can be related to PMDD. I'm just curious from people watching, anybody resonate with having PMS or PMDD? And as you guys are answering, we can go ahead and chat.
Again, something completely different in different, or maybe the same. It might be all linked. I see a lot of women going through perimenopause in their late 30s or 40s. Now, a lot of gut health problems, symptoms, mainly bloating and abdominal pain and discomfort, something that they never had it before, never experienced it before, and now suddenly in their 40s. So is there a link between that gut and hormones? We
Oh,
see
absolutely.
everything is linked to hormones.
Yeah. Well, I do want to answer. Okay, so I do want to talk about the gut, and you all can let me know if you've got gut specific questions. You can drop them in the comments. I did see Mandy, this is your second time posting it in there, so I don't want to miss it.
Yes.
Can you have PCOS if you only have additional follicles and do not particularly have the other two parts of the Rotterdam criteria? This is a great question. So here's the thing. The Rotterdam criteria has its limitations. In fact, what we know about PCOS and how we're practicing now will not be the way that we practice in 20 years because we will get new information. This is a condition that has been understudied, underfunded, and it isn't until 2024 that the US government's like, hey, maybe we should fund women's medicine, and fund that research a little bit more. So we're way behind. Now, with PCOS, if you suspect you have PCOS, we have to rule out other conditions that could be going on. But if things have been ruled out and you're like, no, I have these excess follicles, the question I always ask is, how are they measuring for hyperandrogenism? Free testosterone is so important in women. We look at total and free testosterone, but we also need to look at DHEA sulfate. We need to look at what is coming from the adrenal glands as well. And then there's other additional androgens, but those are three really key ones. And looking at your sex hormone binding globulin, because if that's really high, then your free testosterone should be low. It's absolutely what we should see. So there's that piece. The other is if you have a lot of follicles, get your AMH measured. So that anti-Mullerian hormone that we talked about for fertility, we know that if we see that over 4, it's a high probability that we have a PCOS patient in front of us. And that's where I will also look at fasting insulin, fasting glucose, hemoglobin A1C to see what's going on with the blood sugar. So hemoglobin A1C tells me what's your blood sugar been like over the last 3 months. And then I also like to look at a CRP, C-reactive protein, so I can look at inflammation. And if we're seeing that, hey, everything else is not right, but I can't say that oh, you absolutely have irregular periods, because here's the thing. The way I see PCOS patients all the time that are not having irregular periods, or they had hyperandrogenism, they had some symptoms in the past, they don't have that anymore. And when I get into how are they living their life, they're like, I weight train 3 to 4 times a week, I exercise, I'm making sure that my fiber is up. They start going through exactly how you manage PCOS. And so what am I going to do? Tell them, hey, for 3 months, can you just binge eat ice cream and lay on the couch? Then I would probably be able to diagnose it, but I'm not going to do that. And so you have to work with an experienced provider to look at what else might be going on and what could possibly be, be driving your particular form of PCOS, because we know that there are 4 phenotypes and there are different ways that PCOS presents. But it's not something that the research has completely caught up with. I will say the 2023 guidelines now say AMH can be included in diagnosing this symptom picture. So to get back to the piece about gut health and hormones, which is perfect for PCOS as well, because with PCOS having that inflammatory component, we always have to look at what's going on in the gut. So with the gut, the PCOS, endometriosis, we now understand that these two have a gut component. So there is really, I think, no condition on the planet that we shouldn't look at, what's going on in gut health. But, one thing I will say, as we talk about having PMS, PMDD, PCOS, endometriosis, the estrobolome in the gut is so very important. Now, the estrobolome is the microorganisms that interact with your estrogen. They help keep your vagina healthy. They help keep your estrogen in balance. However, if there's dysbiosis, which can happen so easily, like you spent a weekend drinking too much alcohol, you had to take antibiotics because you absolutely had an infection, or you got food poisoning, like there, or you're on the birth control pill, like there are so many ways that we can develop dysbiosis. If that exists, then those organisms can produce more of an enzyme called beta-glucuronidase. Now, beta-glucuronidase is important in helping you keep your estrogen levels up and around, but it can be problematic when there's an imbalance and we can have far too much of it. In the case of PCOS, estrogen excess symptoms are really common because we have anovulatory cycles happening in that condition. In cases of endometriosis, that is an estrogen dependent and often an estrogen dominant condition where estrogen is causing proliferation of the lesions. They're bleeding, there's inflammation, highly problematic. And with PMS and PMDD, if you all missed it, you're going to want to go back and like watch the beginning of this. We talked all about how that can be related to the imbalance of estrogen and progesterone. And that again can come back to the gut.
Mm-hmm. Yeah, someone is asking about flu, period flu or cycle flu, a few days before her periods. Is this something that happens to anyone, or is it just a coincidence that she feels flu-y before her periods? And if that's the case, is there any solution for this?
Yeah, so that's what I was talking about with the histamine connection to estrogen previously. So if you missed that, definitely go. You're going to want to rewatch this and listen. I go into detail in this about is this normal, and talk about histamine, talk about prostaglandins, talk about inflammation and what's happening there. A couple things that can definitely help: increasing vitamin C in your diet and considering supplementation. Magnesium, I prefer magnesium glycinate in women because that glycine molecule really helps you feel calm. It can help with sleep. So magnesium can help in these situations. Omega-3 fatty acids, so eating more cold water fish. You can make an at-home Caesar salad, and you can do that with adding anchovies in there so that you're getting those omega-3 fatty acids. There's a lot of creative ways to get that in. But if you're experiencing that, you're experiencing acne, you're having cramps, supplementing with omega-3 fatty acids is usually a good call. You just want to make sure anytime you're supplementing with omega-3s, and this is something that we do in the Dr. Brighten Essentials company, is we make sure that we're screening those. They're coming from the highest source. We're not blending them with things like canola oil, because that happens sometimes on the market, and that we're checking that they don't have contaminants in them so that you are getting the best quality, because omega-3s, they're super important for brain health. We don't want to risk taking something for brain health that's actually going to be detrimental to our brain health. So we definitely want to just make sure that we're looking at the dietary component and then bringing the supplements on top of that. And then the last thing I'll say is drinking nettle tea. That can be helpful because it contains quercetin, and that helps stabilize the mast cell, and that can help you feel better. So all the things I just said, those are going to help you address both your histamine and help you address the prostaglandins.
Mm-hmm. Very useful. I love your Insta account, all those educational videos, great. There is something about ADD and ADHD, the link between and PMDD or PMS.
Yeah.
Can you just explain a little bit about that?
Absolutely. So this is something that I will advocate for all day, every day. And that is that anytime I have a patient who comes in and they've got the label of PMDD, if I suspect PMDD, I'm already going to start the screening process and getting you over to somebody to evaluate you for autism or ADHD, depending on what else is going on and the symptoms that you're presenting. But anytime I get a patient who's had PMDD labeled, essentially just labeled on them, providers often miss this connection. And to be fair, research for a very long time on autism and ADHD has only been on young males. And the powers that be in medicine teaching us all were like, well, women don't present that way. Of course we don't present like boys, like small boys, but a lot of women have fallen through the cracks. So With that, it's important to understand that PMDD disproportionately affects the autistic and ADHD community. If you have autism, you know your chance of having PMDD, that correlation is over 90%. In people with ADHD, we see that 50, or excuse me, close to 50%. The recent stats are saying around 46% report having PMDD. So why is this important? Because the average run-of-the-mill treatment that they're going to give to an average person is not going to work for you, because your issue with processing and with your hormones, it isn't exclusive to the luteal phase. The luteal phase is where you lose the capacity, you lose resilience and the capacity to mask, to manage. And that's because as estrogen and progesterone are fluctuating, dopamine, serotonin, histamine, these other brain chemicals are changing as well. And you absolutely deserve accommodations every day of your cycle, not just during that luteal phase. We also have to recognize that it is just not enough to say, this is how we've always treated PMDD, and you're neurodivergent, but we're just going to treat you the same and then send you on your way. We have to look at the fact that sensory processing issues, like auditory processing issues, for example, those can be around all of the time. One of the top missing causes of fatigue that I see, so we often think iron deficiency anemia, and we think B12, and we think all of these things, and that's all true. But undiagnosed ADHD and autism is a huge cause of fatigue in women. Why? Because it is absolutely exhausting to be neurodivergent in a world that says, we will do nothing for you. We expect you just to figure it out and show up the same. And when you're feeling fatigued, that's your brain. It's your brain feeling fatigued. It is stress. Now, as I just said, stress can cause all kinds of hormonal issues, but in addition, it can cut off years of your life. And so that is why I'm like, great, we know that you're dealing with PMDD, but really, who cares? Because there's this bigger issue going on that we have to be addressing every single day of your life. And what I find is that when we're addressing those things, like we're making sure that people have the accommodations that they need, their PMDD is much more manageable. They don't get from follicular phase to crashed in the luteal phase and feeling completely overwhelmed and completely frazzled. I also take issue with labeling autistic and ADHD women with PMDD and acting like, oh, well, you just have like mental health issues and there's something wrong with you. There's not anything wrong with you. You got a different manual in how you operate, and our society was built by people who got a separate manual. Mm-hmm. They're operating out of red manual. You got green manual. And the problem is that they're like, just use our manual, and it doesn't work that way. And so we absolutely have to, one, honor these people are not broken. They don't need to be fixed. There's nothing, there's some people in the community who are like, this may very well be an evolutionary adaptation. And I'm like, it may very well be. It may very well be something that, we see that. And I think so often it's labeled as like, you're problematic. You have to be fixed. You have to be, medicated. Medications can help. But I think we also just need to hold space for the fact that sometimes people have to restructure their life and do things in a different way that actually work for them, not the way that they've been told has to work for everybody in life. And I think as women, that's particularly challenging because we're always told to fit into the mold and never create the mold.
Mm-hmm. Yeah, I agree with all what you said. Someone was saying that's recently diagnosed with ADD and PMDD and was started on SSRIs, and they wished her all the best, and that was the whole thing that she received.
Yeah.
So that doesn't sound right to me.
No, especially when PMDD patients, they can have the risk of suicidal ideation. That's how extreme their mood symptoms can be. To put someone on an SSRI and be like, wish you the best, that's very short-sighted. But also, if you have ADHD, like, the, obviously this person is not equipped to help you. I am not a mental health therapist. I am not somebody who, I'm not a psychiatrist who medically manages ADHD or autism in that way. I'm not going to be writing you. I mean, it's in my scope. I could write SSRIs, but I'm like, that's better left to the person who has expertise. In fact, what we know is that when the primary care providers, the OB-GYNs, the PCPs, when they're the ones managing mental health and prescribing these meds, people don't actually get the right help that they need. They struggle, they end up on polypharmacy. It is better left to a psychiatrist, in my opinion. And I would say better to get people with coaches who understand ADHD and autism and can help them navigate all of that.
Yes.
Now, SSRIs can absolutely help. They can absolutely help, but so can saffron, and so can 5-HTP, and so can, exercising intensely and getting sunshine outside. And so I think we always have to look at what layer of intervention do we need? And even if we need the SSRI, then we still need sunshine and exercise and all of these things. And I even counsel patients that, listen, if your SSRI starts to not work for you, sometimes bringing on something like saffron in addition can be helpful. You can't, just for people listening, if you're on SSRI, don't bring on 5-HTP. If you get serotonin 6 syndrome, you're going to be so pissed at me for even saying 5-HTP, that we don't mix those two together. If you're on a medication that keeps serotonin around, we don't take precursors to push more serotonin production because you're not clearing it in the same way. So just a word of caution and a reminder that I'm a doctor, but I'm not your doctor. So you got to talk to your doctor about what's right for you, because you're an individual and you need a complete assessment of your entire history and your life. And I saw someone say ADHD and perimenopause. Listen, there is I want to say a boatload, but it's far more than a boatload. There is just like so many women in their 40s now receiving the diagnosis of ADHD and autism. And I hear all the time from people being like, oh, well, how would they have had this their whole life and not know it? Your hormones give you superpowers. And when they start to go, you cannot mask, accommodate, keep up in the same way. And let me tell you, friend, that is not because you're broken. That is because your body says, listen, we're in our 40s. Let's make it to our 80s. And the way to get there is to stop all of that and to actually give yourself permission to be. But this is where I talk so often about, if you're experiencing PMDD now, or you're having anything that looks like autism and ADHD, like, getting the diagnosis is hard and it's exhausting and it's time consuming and it's expensive. And sometimes it comes with a stigma, and sometimes you can't even relocate to another country if you have these diagnoses. So we have to honor why someone might not want to get it. But if you're thinking like, that might be me, know that it does not get better in perimenopause. It gets a lot worse. And you need to build your toolkit now and start thinking about what's going to work. And if you're going into, what I will say though, is that once you're in menopause and you're on hormone replacement therapy and it's consistent and you got it dialed in, it does get a lot easier. But in the perimenopause, will I ovulate? Won't I ovulate? What's estrogen doing? Where's progesterone phase? That's not a picnic.
Mm-hmm. Someone is asking about supplements for ADD or ADHD. Anything that you seen that helps with all those symptoms and the distraction or the focus?
Yeah, so there's so many things that can be helpful. One thing that I will say is creatine. This is something that is typically used by athletes for energy in their muscles. We know it's great for brain health and it can be used for energy. And I find that it can help with ADHD. And I've seen patients who are like, I am focusing more. I'm not fatiguing as regularly. So that is one thing that I will say. There are lots of things. It just depends on like what's going on. Like, you've got ADHD accompanied with anxiety or autism accompanied with anxiety. Like, we might bring in things like L-theanine, passion flower, and those things can really help with calming the nervous system, helping you feel more regulated. Omega-3 fatty acids, I will say those again because I think they're so important in feeding the brain and supporting the brain. We also know that if there are suboptimal levels of nutrients, I'm not talking about deficiency, right? So many of what we see in terms of nutrition recommendation is like, you don't need that much vitamin C because, like, you know, you don't have scurvy. And it's like, I'm not going to wait to bottom out. I want optimal. If you don't have, and so what we see with ADHD is if you do not have optimal levels of magnesium, of zinc, of selenium, like many of your minerals, this can start to affect you. And part of that is because of how it's going to affect your hormones.
I definitely recommend always to patients to do some good base nutrient diagnostic test to see if there's any deficiency or if we can optimize the levels, definitely to work on and address that too, for sure. What about changing subject to perimenopause and menopause women and anxiety and mood changes? Now we talk so much about it everywhere we're talking, and of course one of the antidepressants treating these women who sudden onset of anxiety and depression during perimenopause. We see that many times. So what is your recommendation on treatment and supporting these women?
Awesome. I would love to talk about that piece. I do have to let you know, this is going to have to be the last question because I do have to go. I have another live app scheduled after this, but this is a great place to wrap this up. So if you're experiencing anxiety, depression, and you're in perimenopause, we have to ask about estrogen and progesterone. So progesterone, like I said before, linked to anxiety, and estrogen, when that starts going low, we can absolutely see people becoming more depressed. And so this is where instead of reaching for an antidepressant, we should be reaching for hormone replacement therapy. We know that, you know, historically, it was like about a decade ago where paper came out telling us, hey, middle-aged women are dying of a benzodiazepine overdose like we've never seen before. They're high risk of, yes, because they're being over-medicated instead of being given hormone replacement therapy like they should. Now, if you're not a candidate for hormone replacement therapy, like I said before, some things that can help with mood. So L-theanine, passion flower, even phosphatidylserine if it's coming from the adrenals and cortisol, these things can help with some cases of anxiety. Again, we always want to have that nutrition and lifestyle foundation dialed in. And then there's also the piece of depression that we talked about. So things like turmeric, saffron, magnesium, B vitamins, and 5-HTP, those can also be beneficial because when estrogen goes low, serotonin is going to follow. And so you need the cofactors to make serotonin, but you also need the precursors to make serotonin. Those can be really beneficial. Keeping inflammation low can be beneficial. And then, of course, it always wins. Exercise absolutely always wins when it comes to mood.
Great. Last question. What's your thoughts on intermittent fasting, inflammation, PCOS, and what do you recommend on that? So
that's also a huge topic. Yeah, so I would recommend everybody go to drbrighten.com and look up intermittent fasting and menopause. That article, and I want to point you there first because I do have an intermittent fasting for women article, but the one on menopause, I feel kind of remiss, but I spent more time putting together like a whole chart of when do you get the benefits, talking through exactly how to get started and all the nuances around it. Intermittent fasting can be great for inflammation, absolutely great for PCOS, and definitely fantastic for perimenopause, menopause. However, it doesn't work for everyone. There's a lot of nuance to the conversation of what you should be considering and understanding that fasting to have benefits is often just closing your kitchen at dinner time and not eating again until breakfast and giving yourself 12 to 16 hours of sleeping. And so for anybody who's like, I tried it, I tried to not eat all day. I'm like, no, no, no. Don't eat while you sleep. That's the key there. But I would point people to those resources because it's a very, I mean, we could spend an hour just talking about that.
And last thing is about your book. Is This Normal? Your last book is amazing. And just let us know where people can purchase it from.
Yeah, you can find Is This Normal and Beyond the Pill and my first book, Healing Your Body Naturally After Childbirth. They're on Amazon, which is where everybody's buying books these days. And then you can also find them on drbrighten.com. You can find them, there's different bookstores. You're in the UK. There's a bunch of bookstores like in person that you can go to in the UK. So pretty much anywhere that you can get books, you can find it.
Great. Amazing. Lovely, Dr. Brighten. Thank you very much for joining us today. It was amazing. Lovely.
Thank you so much.
So much information, useful information.
Well, awesome. Well, thank you so much for having me. I just heard my timer go off of my notice for my next live.
All the best. Take care.
Yeah, thank you. Take care.
Thanks. Bye-bye.
Bye.